Hi, I'm Dr. Hisham Atwa, founder of Long Island Laparoscopic Doctors and the Chief of General Surgery at St. Charles Hospital. I'd like to welcome you to our website, and I'd like to thank you for taking the time to participate in this webinar, The Journey to the New You. The main objective of this webinar is to help you break the ties with obesity and to help you live a longer and healthier and more fulfilling life. Our mission at Long Island Laparoscopic Doctors is to help you identify and appreciate your health needs. We strive to bring you the best possible selection of weight loss therapies, treatments, and supplements to help you live the life that you deserve and desire. We take personal pride in overseeing the details of each case in order to provide you with the best solutions to overcome the obstacles of obesity. These solutions include bariatric surgery, medical treatment, diet and exercise, behavior modification, and group support therapy. During this program, we will cover together 5 key subjects that may change the rest of your life. First, what is obesity? You will learn how we as medical professionals view obesity. How do we define it, measure it, and classify it? We'll review the influences in our lives that contribute to whether a person becomes obese, and most importantly, where you fit in. We will then discuss the financial and health costs of severe obesity to you as a person, your family, and society at large. Our board-certified and fellowship-trained surgeons provide the latest techniques in safe and minimally invasive surgical weight loss procedures, and you will see those today. We will explain how you may get started and how we feel your choice for surgical weight loss care should be Long Island Laparoscopic Doctors. To begin with, we describe obesity as a chronic metabolic disease caused by multiple and complex factors, including increased calorie intake, decreased physical activity, and genetic influences. It is a disease of excess fat storage with a number of associated comorbidities or health conditions such as diabetes, sleep apnea, acid reflux, and high blood pressure. If you've been struggling with your weight and have tried diet after diet and feel it is your fault, it's important to realize that there is hope. Obesity is a disease just like diabetes or high blood pressure. It's not your fault. There is hope. And as you will learn today, we can help. Morbid obesity is a health condition defined as being at least 60 to 100 pounds over your ideal body weight. A formula used to determine morbid obesity is body mass index, or BMI, which is calculated by using your height and weight to determine your overall body composition. Specifically, obesity is an excess of body fat tissue. It's associated with increased fat cell size and number. Population studies indicate a direct correlation between body mass index, disease, and death. Ranges of BMI have been established for the purpose of analyzing and developing guidelines for effective approaches in the treatment and prevention of obesity. It is now accepted that an increase in the body weight of 20% or more above normal constitutes a health hazard and is considered obese. People with mild obesity may be at risk if they have associated comorbidities or the risk factors of a disease. So where do you fit? On the left-hand side of this website, you will see a button that says Calculate Your BMI. If you enter your height and weight and press the Calculate button, our website will display your BMI. There's a chart that would also help you identify your BMI in our program handouts that you may download at the end of this program as well. As an example, if you were an adult with a height of 5 feet 10 inches and your weight was 300 pounds, we would calculate your BMI to be 43, placing you in the morbidly obese category. Your normal weight range is also displayed. To qualify for most bariatric surgeries, a patient will need to have a BMI of between 35 to 39, with at least one or more comorbidities in their medical profile. Patients with a BMI of 40 or more are accepted without comorbidities. Recently, the FDA has approved one procedure, the lap band, for patients with lower BMIs of between 30 and 35, with one comorbidity. We will talk about comorbidities more shortly. However, you should not be disappointed if you are a couple of pounds shy of one category or the other. Home scales frequently are not as accurate as our office medical scales, and that is an important reason to schedule a personal office consult so you can be properly evaluated and we can help you get the treatment you want. 5 years ago, studies showed that more than 65% of adults were overweight or obese. 32% of children were overweight, and about 5% of adults were morbidly obese. The total of medical costs for obesity in 2003 was reported to be $75 billion, with 325,000 obesity-related deaths occurring annually. A recent study showed that in 2012, a morbidly obese person's medical costs are likely to be $2,700 per year higher than if they were not obese. Nationwide, that translates into $190 billion annually, or 20% of the national health expenditures. Today, the number one cause of preventable death in the United States is no longer cancer, it's obesity. Obesity results from an energy imbalance which involves eating too many calories and not getting enough physical activity. Body weight is a result of genes, metabolism, behavior, environment, culture, and socioeconomic status. Despite obesity having strong genetic determinants, the genetic composition of the population doesn't change rapidly. Behavior and environment play the largest role in causing people to be overweight, and therefore these are the greatest areas for prevention and treatment. The large increase in obesity in the United States in recent years therefore reflects changes in behavior and environmental factors. Let's look at some of these factors. As a society, we've come a long way since primitive men who spent most of their time awake searching and hunting for food. However, your body stores food and reacts to dieting in much the same way as primitive man's did to starvation. Today, we have more gadgets and consumer lifestyle advantages that lead to less and less output of calories. The result of this is predictable, and the next slide will illustrate my point. What is wrong with this picture? Given the option of taking an escalator to or stairs to and from the gym, what would you do? Let's look at some of the other changes in our environment and behavior in the past 10 to 20 years. In the past 2 decades, across all of America, we have seen a dramatic change that has broadened food options and eating habits across the entire population. Grocery stores everywhere stock their shelves with greater selection of more products than ever before. Much of these new food choices are high-caloric, prepackaged foods. Fast food restaurants and soft drinks are also more accessible in malls, commuter transit locations, and even schools. While such foods are fast and convenient, they also tend to be high in fat, sugar, and calories. People may be consuming more than twice as much in calories in a meal or snack than in the past as a result. A cup of coffee and a muffin today is equal to what a normal meal was just 10 to 20 years ago. We live in a country where everything is supersized. Just compare today's bagels with all the assorted toppings to bagels a few years ago. Obesity is life-threatening, and many people do not realize the profound effect that severe obesity has on the mind and body. That includes the severely obese themselves. The severely obese individual faces health, social, and psychological problems that are not fully recognized by society. Obesity is not caused by a lack of willpower as is commonly believed. Obesity has overwhelming consequences from the perspective of poor health. Comorbidities such as high blood pressure, infertility, arthritis, diabetes, sleep apnea, heart and lung disease, and a shortened lifespan go hand in hand in the lives of most obese individuals. For some, even everyday tasks such as getting in and out of a car can be a challenge and drain their strength. With obesity comes a compromised quality of life and critical illness. Medical and behavioral interventions rarely result in significant, sustained weight loss necessary to improve health. To date, surgical therapy is the only effective tool to combat the disease of morbid obesity. The emotional treadmill that many obese people find themselves trapped in is crushing. Obesity often imparts a negative self-image and feelings of social isolation, which drives a desire to eat to feel good. But the so-called comfort food is rarely just that, and the cycle perpetuates itself. One of the positive aspects of participating in our bariatric program will be the release you will feel from being on this emotional treadmill and the pride of self-accomplishment and the release from anxiety that comes from being in control of one's body and life again. In 1991, obesity as a national problem hardly raised a flag statistically. Obesity was a factor in 10 to 15% or less of the population in just about all of our states. However, in just 15 years, the complexion of the population that is overweight has dramatically skyrocketed, and lack of willpower and genetics cannot account for this change. The amount of the population that is now overweight is 25% or greater, and fast becoming the norm in almost every state. Here in the Northeast, we are already at 30%, and this is not an achievement that we are proud to report. Obese patients are at increased risk for developing many medical problems, including diabetes, hypertension, high cholesterol, cardiovascular disease, stroke, sleep apnea, gallbladder disease, gout, and arthritis. Certain cancers are also associated with obesity, including colorectal and prostate cancer in men, and endometrial, breast, and gallbladder cancer in women. Look at this list and ask yourself, are you suffering from any of these ailments? If so, what is the cost to you in medication, medical bills, or lost work as a result of having one of these problems? Here we have compared the effect of BMI and age with the prevalence of it in the population, and you can see that diabetes is closely associated with obesity. As your BMI goes up to the level of qualifying for bariatric surgery, you become significantly more prone to developing diabetes. Excess body weight is also associated with substantial increases in death from all causes, in particular cardiovascular disease. More than 5% of the national health expenditure in the United States is directed at medical costs closely associated with obesity. We see similar relationships between body mass index and other morbidities such as asthma, arthritis, high blood pressure, and cancer. And that is why it is so important to be aware of your BMI and make a commitment to lower your risks of illness and death by resolving your problems with obesity. Obese individuals may suffer from social stigmatization and discrimination, and severely obese people may experience greater risk of impaired psychosocial and physical functioning, causing a negative impact on their quality of life. As a result, we see many psychological problems, more common among obese individuals such as depression and binge eating disorders, than they are in the general population. Today, obesity is the leading cause of preventable death in the United States. 30% of cancer deaths in men are from obesity. Most type 2 diabetes, sleep apnea, hypertension, and cardiovascular disease are caused by obesity. For those who remain severely obese after repeated attempts at dieting and other programs and are physiologically and medically qualified for surgical weight loss procedure, not having the treatment is not an option. What price would you pay to live an extra 10 to 12 years? The options outside of bariatric surgery for long-term obese individuals are limited, and perhaps most of you with us today have tried some, if not all, of these treatments. In fact, to qualify for bariatric surgery, you will have needed to have first previously tried one or more of these approaches over a period of time. The problem for severely obese individuals is not losing weight alone, it's keeping it off. And that is the problem that these alternative treatments poorly address in the lives of the obese. Without weight loss surgery, 99.5% of obese patients will regain their weight in 2 years. Dietary intervention almost never works. Physical activity alone does not lead to weight loss. Behavior modification programs require ongoing professional contact, and the failure rate is high. Drug treatments are ineffective because weight is typically regained when treatment ends. Weight loss surgery and lifestyle changes are the most effective approach for long-term weight loss success. Let's look at the reasons. Earlier, I spoke about the body's reaction to the food restrictions on many diets. What I was referring to is the impact that dieting has on our metabolism. When we diet, our metabolism begins to slow down. The body thinks it's experiencing a famine. It's in starvation alert mode and is trying to store every calorie. The result is that we gain weight with a vengeance, faster than ever before. In this mode, the body starts to reduce the production of the hormone leptin, which gives the body its feeling of fullness and increases the production of the hormone ghrelin, which increases hunger. It becomes an uphill struggle for most dieters, and they eventually give in to past patterns of eating. What about exercise? We've all seen the great weight loss accomplishments shown by contestants on the TV program The Biggest Loser. But is that a real solution for most of us to consider in our everyday lives? 24/7 personal training, secluded from work and family, working out strenuously for 8 hours a day? While there are many benefits to moderate exercise, to lose weight, experts recommend that you do 60 to 90 minutes of moderate to vigorous intensity physical activity on most days of the week. In addition, you should follow a nutritious eating plan and consume fewer calories than you burn each day. Even if we can dedicate an hour or two every day to strenuous exercise, that's a tall order for anyone who is obese and may already have joint and other health issues. So then what about diet medicines? Currently, most available weight loss drugs approved by the FDA are for short-term use, meaning only a few weeks or months. Obesity often requires long-term treatment to promote and sustain weight loss. As in other chronic conditions such as diabetes or high blood pressure, use of prescription drugs may be appropriate for some people but not for others. While most side effects of prescription weight loss drugs are mild, serious complications have been reported. These drugs are not a cure-all for obesity. Studies show that diet alone, exercise alone, diet and exercise, or diets with appetite suppressants usually result in minimal weight loss with rapid weight regain. At the best, even the newest diet drugs such as Belvac or Cunexa demonstrate that a 275-pound person would approximately lose 16 pounds per year as compared to 50 to 70 pounds through weight loss surgery. For those already afflicted by obesity, behavioral adjustments alone do not solve the problem either. In a study recently published in the New England Journal of Medicine, patients with obesity were given lifestyle coaches to help them lose weight. The result was that after working closely with their coaches for 2 years, patients lost on average only 5% of their body weight, and there was no significant changes in blood pressure, blood sugar levels, or cholesterol levels to suggest a change in the risk of obesity-related disease or death. The patients may have looked a few pounds lighter, but they didn't appear much healthier. Now, studies showing the results of different weight loss strategies are pretty one-sided, and after 2 years, non-surgical treatments rarely show more than 10% excess weight loss. The 3 most common weight loss procedures average of 50 to 60% of excess weight loss in the same period. A recent 2012 HealthGrade's trend report sums it up this way, by forecasting that in 20 years, 4 in 10 Americans will be obese, and the number of severely obese adults will be more than double. To address this obesity epidemic, the U.S. Preventive Services Task Force has recommended an intensive, multidisciplinary treatment program for obesity, and has declared that bariatric surgery is the only option that effectively treats severe obesity in people for whom more conservative treatments have failed. If you are severely obese, the reasons are pretty compelling. Fear of developing additional comorbidities such as diabetes, high blood pressure, and sleep apnea. Diets don't work. The track record for surgery is impressive. And the big motivator, a 30 to 40% reduction in mortality. In addition, our patients tell us that they want to decrease the number of medications they are taking, have more energy and mobility, and generally feel better about themselves. They also want to spend more time with their children and grandchildren. To review what we have said earlier, to qualify for bariatric surgery, you need to have a BMI of at least 40 or a BMI of 35 to 39 with significant obesity-related comorbidities. Patients with a lower BMI of 30 to 40 have been approved for the adjustable gastric band or lap band procedure. In New York, most insurance carriers have both in and out of network coverage for this type of surgery. However, each plan may have their own additional criteria. Some of the most common are listed here. One of the advantages of coming to Long Island laparoscopic doctors for your treatment is that we will communicate with your insurance company and verify your benefits and help you get approved for the surgery. Simply call our office to arrange a consult, 631-476-9296. Of the common major surgeries performed each year in the United States, bariatric surgery is one of the safest procedures you can undergo. There are approximately the same numbers each of coronary artery bypass or CABG surgeries for the heart and hip replacements performed each year as bariatric surgeries. Yet the mortality rates are significantly higher for these procedures. 700,000 gallbladder removal operations are performed each year, and the mortality rates are 3 times as high as those for bariatric surgery. The biggest reason for this is patients for bariatric surgery are pre-screened by additional specialists prior to surgery, and we go to additional lengths to prepare you for surgery to avoid such things as a blood clot, which is the most frequent complication for major surgery. Besides blood clots, there are other complications that one can experience after all major surgery. The ones we have listed for you here today are the principal ones. But there are others, and at Long Island laparoscopic doctors, we are able to minimize the potential for any of these from occurring. We are pleased to say that we have been on the vanguard of the latest techniques in minimally invasive surgical services. In the past, and even in some surgeries today, operations were performed by making a large incision in what was called an open procedure. This leaves the body more susceptible to complications after surgery, because you are often under anesthesia longer and the body cavity is more exposed. The majority of bariatric procedures are performed through laparoscopic techniques. This is less invasive and requires only small incisions and a tiny camera. It's associated with less pain, bleeding, complications, and scarring. Additionally, less invasive surgery methods tend to require a shorter hospital stay and a quicker recovery time. After surgery, we'll have you up and out of bed the same day and out of the hospital and home on average in a couple of days. In this chart, we have compared the deaths per 100 of patients who were morbidly obese or had heart disease and had surgery with those that did not. The numbers paint a dramatic picture of why, if you qualify for bariatric surgery, your decision should be a resounding yes. The chance of dying from bariatric surgery is 0.3 to 0.7% versus 6% if those who do not get surgery. There's simply no other options for improving the life expectancy of severely obese individuals than weight loss surgery. Here you can see more evidence that with the increase of your BMI, the mortality rate for both men and women nearly doubles as you enter the area of morbid obesity. Your physician at Long Island laparoscopic doctors will help you decide which procedure is best for your lifestyle. The final recommendation is based on a number of factors and eligibility requirements, including medical history, age, body mass index, and previous weight loss treatment results. These same factors will also affect how much weight a patient can expect to lose after surgery. Whichever option is chosen, weight loss resulting from any of these procedures can significantly improve conditions associated with morbid obesity. Surgery for the control of clinically severe obesity is based on one or more of 2 principles. The first is restriction, whereby the amount of calories or food ingested is controlled by limiting space available. The second principle is malabsorption, whereby the absorption of food is controlled or reduced. This chart provides a quick overview of the innovative bariatric procedures performed by our team. Later in our presentation, we will cover the advantages and disadvantages of each one more in depth. All our procedures pictured are performed laparoscopically. The Roux-en-Y gastric bypass is the most common bariatric surgery. It's sometimes referred to as the gold standard in weight loss surgery because it is the oldest surgery and the one whereby most individuals lose the greatest amount of excess weight. It also requires very little maintenance after surgery in terms of diet or adjustments. It has both a restrictive and a malabsorptive component. One of the newest techniques available is the sleeve gastrectomy. It involves removing 80% of the stomach, leaving only a tube or a sleeve of stomach behind. This restricts the amount of food that a patient can eat and leads to a significant weight loss. It also has less maintenance than a procedure like the lap band and promotes more excess weight loss without causing a malabsorption of nutrients. In addition, it decreases the secretion of the hormone ghrelin, which, as I have mentioned earlier, stimulates the appetite. The adjustable gastric band, also known as a lap band or realized band, is another option that helps patients lose weight by reducing the capacity of food that can pass into the stomach. We implant an inflatable silicone band around the upper portion of the stomach to create a tiny stomach pouch. This procedure has been popular for many years with no cutting, stapling, or stomach rerouting involved. It's considered to be a safer procedure. It also can be be used with patients who have lower body mass index. To better understand how the gastric bypass weight loss surgery works, it is helpful to know how the normal digestive process works. As food moves along the digestive tract, special digestive juices and enzymes arrive at the right place at the right time to digest food and absorb calories and nutrients. After we chew and swallow our food, it moves down the esophagus to the stomach, where strong acid and powerful enzymes continue the digestive process. Food is slowly released into the small intestine, where absorption of the nutrients, vitamins, and minerals take place. Roux-en-Y gastric bypass consists of separating the stomach into two sections using parallel rows of titanium staples. The staples remain fixed and do not migrate. The small upper segment, connected to the esophagus, remains the food functional portion of the stomach, while the lower segment, connected to the duodenum, though still functional, does not deal with food eaten by the patient. In the next phase, the surgeon disconnects the continuity of the small intestine, brings the lower end up to the small gastric pouch, still connected with the esophagus. This section of the intestine is still functional. The intestine is connected to the small stomach pouch by means of an opening about the size of a dime. This allows food to pass directly into the intestine where it's digested. When the small, functioning upper stomach pouch is full, at first this will occur with only a nibble or two, patients experience a sense of fullness. In this way, and because the appetite will also be reduced, the intake of food is dramatically limited. This is what enables weight loss. What food is eaten is handled by the body quite well. On average, patients will lose about 100 pounds, or up to 2/3 of their excess weight in 1 year. Some people lose a little more, some a little less. Weight loss will continue during the second year at a less rapid rate. The advantages of Roux-en-Y gastric bypass include superior weight loss, which is about 60 to 70% of the excess weight at 2 years, and the best elimination of comorbidities such as acid reflux, and 80% resolution of type 2 diabetes almost immediately after surgery. Early and late complication rates are reasonably low, and operative mortality ranges from 0.2% to 0.7%. Disadvantages of the Roux-en-Y gastric bypass include a longer operation, about 2 hours, the potential for leaks, and other complications. A small number of patients experience dumping syndrome symptoms. This is a short-term feeling of nausea and sweating after eating sweets and simple carbohydrates. Patients who have bypass surgery require an additional intake of vitamin supplements. Here is a short video showing the gastric bypass procedure.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer nutrients and calories being absorbed. It reduces food intake by cutting and stapling the top of the stomach to create a small pouch about the size of a golf ball. The small pouch is then connected to the lower section of the small intestine. Food then passes directly into the lower portion of the small intestine, bypassing most of the stomach and upper intestines. Hundreds of staples are used in this procedure.
Successful celebrity bypass patient Star Jones from the TV show The View, Al Roker from NBC Today TV show, and Randy Jackson of American Idol. The average stomach can hold 1 to 1.5 quarts of food at a time. In the sleeve gastrectomy procedure, the stomach is trimmed to make it skinny and have a shape of a banana, about 2 to 3 ounces, by stapling off and removing 85% of the stomach. The unused excess stomach is then removed. As a result, patients will feel full after eating small portions of food and therefore eat less. This procedure, like the lap band, is purely restrictive. There's no rerouting of the intestine, thus the gastric sleeve surgery does not produce any malabsorption of nutrients or dumping symptoms. On average, patients see a 60 to 90 pound weight loss in the first year after surgery. The majority of patients with diabetes, hypertension, sleep apnea, and high cholesterol will experience resolution of these diseases after surgery as well. This operation has many pluses. Since the operation doesn't involve any rerouting or reconnecting of the intestine, it's a simpler and shorter operation than the gastric bypass. Unlike the adjustable gastric band procedure, the sleeve gastrectomy does not require the implementation of an artificial device inside the abdomen that can require replacement or needs adjustment. Because the stomach continues to function normally, there are far fewer restrictions on the foods which patients can consume after surgery. The quantity, of course, will be considerably reduced. Patients feel this is a great advantage, as is the fact that with the removal of the majority of the stomach, the hormone ghrelin, which stimulates hunger, is virtually eliminated, thus putting out the fire to eat that many obese individuals feel drives their eating habits. To recap, the sleeve procedure has been gaining in popularity for these reasons. Over 80% of type 2 diabetes cases are resolved. Hypertension is also improved or resolved in many patients. With the sleeve gastrectomy, there is no foreign body to break, slip, or erode. Unlike the adjustable gastric band, there is nothing to be adjusted, and the weight loss is quicker than the band. The feeling of fullness that you get from the sleeve gastrectomy is much more satisfying than the feeling of obstruction or discomfort that you might get with the adjustable gastric band. The sleeve procedure can be performed on patients that otherwise do not qualify for gastric bypass, such as those with anemia or Crohn's disease. The weight loss is generally quicker than the band. The sleeve has a very similar recovery to the band and is also performed laparoscopically. The sleeve has a very similar outcome to the gastric bypass. without having malabsorption of your food and with a shorter down and recovery time. The disadvantages are few, but you should be aware of them. Besides the possible complications common to most surgical procedures, leak or other problems related to stomach stapling can occur. In addition, long-term studies related to sustainable weight loss have not been completed, and there's a potential for slower weight loss than the gastric bypass. The adjustable gastric band is one of the top surgical procedures used by surgeons to treat obesity. Our surgeons use laparoscopic techniques to place the band around the upper part of the stomach, forming a small pouch to limit the intake and slow the food passing from the stomach into the intestines. The band is connected by a tubing to a port, which is placed under the skin during surgery. After surgery, the inner surface of the band is inflated or deflated with saline solution to provide restriction. The fill level can be adjusted through the port access as needed. We don't cut, staple, or bypass any portion of the stomach or the intestine. And this is the safest, least invasive, and least traumatic of all weight loss surgeries. And if for any reason the band needs to be removed, the stomach generally returns to its original form. Gastric band surgery is a popular choice for people suffering with obesity. It's an easily reversible operation, which makes it ideal for people who are on the fence about permanent weight loss surgeries. The band can be deflated and reinflated for people who want to be able to eat more on special occasions, such as on a holiday or weddings. A couple of important things to note. First, drinking and eating simultaneously is not recommended for best results. And secondly, you must be committed to lifestyle change and aftercare to achieve optimal results. This is a picture of the adjustable gastric band and a diagram showing how the port works. As you can see in the picture, once placed around the stomach, tubing connects the band to an access port, which is fixed beneath the skin to your abdomen. This allows us to change the stoma, which is the stomach outlet size, by adding or subtracting saline or salt water inside the inner balloon through the access port. This adjustment process helps determine the rate of weight loss. If the band is too loose and weight loss is inadequate, adding more saline can reduce the size of the stoma to further restrict the amount of food that can move through it. If the band is too tight, we will remove some saline to loosen the band and reduce the amount of restriction. The diameter of the band can be modified to meet your individual needs, which can change as you lose weight. For example, pregnant patients can expand their band to accommodate a growing fetus, while patients who aren't experiencing significant weight loss can have their bands tightened. The gastric band does require more maintenance than other procedures. Most patients are ready for their first adjustment 4 to 6 weeks after surgery. Every 4 to 6 weeks or as needed, you will return to the office for a short visit to check the fit or restriction of your band. If you're losing 1 to 2 pounds per week, you will not need an adjustment. The adjustable gastric bands, both the lap band and the realized band, offered by Long Island laparoscopic doctors, are uniquely constructed to be both durable and easy to adjust to a patient's weight loss and lifestyle needs. In over 15 years and almost 750,000 lap band procedures, major complications including mortality are exceptionally low for this procedure. In response to the need to provide an option to approximately 25 million Americans with lower than prescribed BMIs for weight loss surgery who could benefit from the treatment, the FDA has approved this surgery for the lap band system. If you have a body mass index of 30, plus at least one obesity-related comorbidity conditions, such as heart disease, type 2 diabetes, high blood pressure, or sleep apnea, you can now qualify for this procedure. The change in patients' attitudes, lifestyle, and appearance in a relatively short period of time are remarkable. Here's Michelle before surgery, and here she is a couple years later, going from barely being able to exercise to running 5K road races. Celebrity lap band patient Corey Harrison from the TV show Pawn Stars, and this is professional golfer John Daly, lost about 115 pounds with the lap band system. I promised to tell you about the advantages of bariatric surgery from head to toes, and here they are, literally from head to toes. Migraine headaches, 57% resolved. Depression, 55% resolved. Obstructive sleep apnea or snoring at night, about 76 to 98% resolved. Asthma, 82% resolved. Heart attacks and cardiovascular disease, 82% risk reduction. High blood pressure, 50 to 90% resolved. Acid reflux or GERD, 72 to 98% resolved. Non-alcoholic fatty liver disease, 90% improved and 30% resolved. Metabolic syndrome, 80% resolved. Type 2 diabetes, 83% resolved. Gout, 72% resolved. Degenerative joint disease and arthritis, 41 to 76% resolved. Quality of life improved to 92% and 90% 5-year reduction of risk in dying. Surgery can help change your life, but it's only a tool, and as we tell every patient, it requires a strong commitment to lifestyle change and a lifetime of follow-up. So where do you go from here if you're interested in having surgery? You've completed the first step today. Your next step will be to schedule an appointment with our office. We will discuss with you and verify your insurance benefits and costs. If your insurance plan requires a referral, you will need to obtain one to us. We will schedule you for a meeting with our nutritionist and arrange for all preoperative testing and consults. You will need to have a clearance from a pulmonary and cardiology doctor. Preceding your hospital stay, you will be placed on a liquid diet and have an upper GI done. Your hospital stay will also be short, and recovery is from 1 to 2 weeks depending on your job, age, and other factors. Thank you for your participation in today's webinar. By attending the seminar, you have not only completed the first step in qualifying for bariatric surgery, but you've also reached an important milestone on your journey to reaching a healthier lifestyle for both you and for your family. I would like to congratulate you on taking this important step with us. Please remember to print out the seminar handouts while you're on our website. I encourage you to view the many videos of patients' experiences as well as bariatric subjects on our website. If you would like to schedule a personal consultation, you can call our office at 631-476-9296, or you can click on Make an Appointment icon on the website. Thank you for listening. I look forward to meeting you.